got a number of questions to go through, and I see the questions already popping up on a Q&A. So I'm going to perhaps sort of start off with some of the questions, and I'll pose some of the questions to Mande and Scott as well. Some of these questions are very, very specific to an individual, so bear with me. But I think you can sort of extrapolate with some of the questions you might have. So the first one was this individual suffers from anemia, which is thin blood for those of you who's not in the medical field, and bradycardia, low pulse rate. And the question is whether it is safe to receive the vaccine. And the short answer is that currently there's almost no contraindication to being vaccinated. And I think that's important. Individuals that have got a history of severe allergic reactions, as an example, are people that need to take extra precaution in that when they do get vaccinated, they probably should be vaccinated at a facility where there's adequate resus equipment. So should they experience an allergic reaction, the medical staff can actually attend to it. But other than that, right now, we do not have any explicit contraindication to vaccination. Mande, anything you want to add?
No, Prof, I absolutely agree with you. And in fact, it appears that even with iron deficiency anemia, if you're on supplementation, that the efficacy of the virus is a little bit improved. I've seen 1 or 2 studies that they're doing overseas in terms of iron deficiency anemia and vaccination. So they say if you're on treatment, you have better efficacy. But I agree with you 100%. Okay,
so the next one was, I catch flu easily. I hardly spend a month without suffering from one. Should I take the vaccine? If you catch flu easily and if you hardly ever not suffer, that is exactly the person that without any exception should receive the vaccine. Vaccines are there to try to prevent you from being infected with the virus. And if that doesn't work, to prevent you from developing mild disease. And if that doesn't work, most importantly, to prevent you from ending up in hospital. So if you are susceptible to repeat infections due to any condition, underlying condition, absolutely, you need to be vaccinated. There are some individuals who got severe underlying medical conditions, which also causes what we call immune suppression. It doesn't allow the body to mount as good an immune response to the vaccine. For those individuals, over time, you might need to get 3 doses of vaccine rather than 2 doses of vaccine. But again, that is something that you would need to discuss with your practitioner to determine whether you fall into that category of individuals that should receive 3 doses rather than 2 doses. Although in South Africa at the moment, there isn't too much latitude in providing individuals with that 3rd dose. However, I do believe that is something that we need to consider. As an example, people in renal failure or also individuals with cancer. And the next one is, if I got chronic high blood pressure, should I get vaccinated? Hypertension, diabetes, obesity. If you tick any of those 3 boxes in terms of your personal characteristics, you are at high risk, much higher risk than the general population in ending up in hospital after you get infected. Your chances of being infected is the same as anyone else, but your chances of ending up in hospital is much, much greater, and your chances of dying is much, much greater. So if you've got an underlying medical condition, or more importantly, even if you live with someone with an underlying medical condition, it is absolutely important that you get vaccinated, because that person that you're living with an underlying medical condition, even if they've been vaccinated, it might be that they fall into that small category of individuals where 2 doses of vaccine is inadequate, and you're wanting to provide additional protection to them by preventing them being unnecessarily exposed to a person that is infected. And the way to reduce that risk is getting vaccinated. Okay, then I'm going to go to the Q&A. Prof. Bloomberg article recently says that more vaccinated people are now being infected. Why is that? Should that be a cause for concern? So like I mentioned, when these vaccines that were developed was developed against the original virus that was circulating, the Wuhan strain. Over time, that virus has mutated, and it has mutated especially in relation to what is known as a spike protein. And now that spike protein is important for the virus to be able to attach to human cells and gain entry into the human cells. Now, what's happened over time is that those mutations has made the antibody, and these antibodies are like protein molecules that are produced in the body, which helps the body eventually to fight off the virus. What's happened is that those mutations have made the antibody that's induced by the vaccine less able to actually attach to that spike protein. It's not lost completely. It's just less able to attach to it. Depending which vaccines you get, vaccines that induce a very, very high antibody concentration can overcome some of that relative resistance to the antibody that has been induced. Now, what happens eventually is that because this antibody is not attaching that well to the virus, you can get these breakthrough infections. The body becomes less capable of sort of eliminating the virus very quickly. It might take a bit longer to eliminate that virus. So yes, people that are vaccinated can get infected, but people that are unvaccinated remain at a much greater risk of becoming infected and developing mild COVID. With the Delta variant, based on the current evidence, it seems that people that are vaccinated are half as likely to be infected with the virus and half as likely to transmit the virus compared with people that are unvaccinated. So your chances of becoming infected, developing mild COVID, and transmitting the virus is reduced about twofold compared with someone that is unvaccinated. But the other important dimension to this, and this speaks to one of the other questions, is that it doesn't mean that the person is not adequately protected against being infected, that a person is not protected against severe disease. The part of the immune system that is important in protecting against severe disease is a different arm of the immune system, which all indications are that particular component of the immune system is relatively, the mutations of the spike protein is not having a major impact on that other arm of the immune system, which is what really assists in protecting against severe disease and death. So even though you might have diminished about a level of protection against mild infection, mild disease and infection, your ability to prevent being severely, developing severe disease and dying of COVID-19 is largely maintained. So it speaks to another issue that has been raised, and that is how long should we wait for a booster, or should we require additional boosters? The third dose of vaccine, which has been advocated in many high-income countries, that is not that much to protect against severe disease and death. That's more to protect against infection and mild COVID. And whether a third dose actually works without needing to supplement every 6 months, which is not pragmatic, even in high-income country settings, remains to be seen. I'm highly skeptical that is the way to go. And in fact, the United Kingdom is a good example where they accept that the virus is here to stay. We need to live with it. And the only way to live with it is by ensuring that we get high numbers of people protected from being hospitalized and dying of COVID-19. And if we're able to achieve that, we can have the virus continue circulating, irrespective of what we do. If the virus, the SARS-CoV-2, the virus that causes COVID-19, is likely to be with us for the rest of our lifetimes. And that is something we need to just become comfortable with. But importantly, we can get back to a normal lifestyle if the majority of individuals are vaccinated and protected against severe disease. Scott, perhaps, or Mande's question for you, how long after you have had your vaccine can one donate blood?
Thanks, Prof. According to the blood transfusion services in the Cape and here in Gauteng, they say 14 days. So after you've had your vaccine, and then 14 days after you've had COVID, as long as your symptoms have subsided. So quite comfortable to donate. And in this time, we really need donors. So don't wait too long, wait till 14 days and off you go.
Okay. So the next question is, what will it take for us to go back to face-to-face lectures? Is that possible in the next year or two? I believe it's possible even before the end of the year, provided we get 80 to 90% of staff and students at the university vaccinated. So this needs to be a collective effort. And at the latest, we should get back to face-to-face teaching and life as normal on campus, or as normal as can be, once we get 80 to 90% of our student population vaccinated. So yes, it can happen. It certainly should happen before 2 years from now. And I think we need to work to ensure that it actually materializes come orientation week 2022 and not 2023. But the only way to achieve that is to ensure that we get the large majority of individuals, at least probably 90% of staff and students vaccinated. And those individuals that choose not to be vaccinated, they should basically bear the consequences of it, in that they would be the ones that would need to be, in a way, they would need to avoid any sort of gatherings. And if they are engaging in gatherings, they would need to take additional precautions which those people that are vaccinated would not need to actually undertake. So I've already discussed the issue of waning of immunity. Like I said, there might well be waning of immunity, but that is more in the context of protection against infection and mild COVID, less so in the context of protecting against severe disease and death. And I think if we try to keep on getting optimal immunity against infection and mild COVID, we will never get back to a relatively normal lifestyle because the virus is going to continue mutating. It's going to continue causing resurgences. But when we get large percentages of the population vaccinated, the frequency of those resurgences become less, the magnitude becomes less, and the number of people that end up in our hospitals and end up dying of COVID-19 would become nominal compared with what we've observed over the course of the first 3 waves in South Africa. So my family members have various underlying health conditions. I'm not sure any of them wanted not being vaccinated. What conditions are contraindicated for vaccination? So I think we've answered this. Like I said, anyone that's got underlying medical conditions and anyone who has got family with underlying medical conditions, you wanting to make sure that those are the ones first in line to get vaccinated, not last in line. There's no medical contraindication. And if you're really, really unsure, speak to some knowledgeable health professional. And I emphasize knowledgeable because just as much as I would strongly advise you against coming to me for heart surgery, equally so, I would strongly advise you going to some cardiac surgeon to get advice on COVID-19 vaccines when the last time you learned anything about vaccines is as medical students. So be selective who you get advice from, and that will assist you in making a proper informed decision. Okay, Scott or Mande, do I need to do anything special immediately after being vaccinated or between the 2 doses?
Thank you, Prof. No, absolutely nothing special except what you've been doing up to now. Maintain hand hygiene, make sure that you're socially distant, make sure that you wear your mask. And even after your 2 doses, there's nothing that's going to stop you. You may still be exposed to and might still get COVID, but you won't get as ill and you might not land up in hospital. And in fact, we're seeing much lower records of our staff and patients coming to hospital after being vaccinated. But you still have to practice hand hygiene and you still have to socially distance. And look after yourself and get out there and enjoy some vitamin D, sunshine. And so, yeah, keep going on with our lives as best as we can. Thank you, Prof.
Yeah, and I think a real concern for students is how long do they need to avoid alcohol? And the short answer is you don't need to avoid alcohol. So you're good to go. Prof. Obviously, do everything in moderation. But I commonly get this question, I've been told not to drink alcohol for 2 weeks or a month after being vaccinated. You need to do everything that you want in moderation. Can I travel internationally between vaccination without risk? I think many countries are going to be insisting on vaccine passports. So right now, there are some countries that don't require vaccination, such as the United States, in fact. You don't require proof of vaccination, but for countries that would require proof of vaccination, you probably would only be allowed in after 2 weeks after having completed your 2nd dose of vaccine. Is it safe to have vaccine if you only have 1 kidney? Won't vaccine harm the other kidney? If you only got 1 kidney, it's a very good reason to be vaccinated. One of the major complications of COVID-19 is you get these blood clots happening in your vessels. And one of the common reasons why people end up dying of COVID-19 in ICU is because of renal failure. If you only got 1 kidney or if you got renal dysfunction, you want to be vaccinated. Yes, you do have side effects of vaccine, but as an example, one of the side effects is with a J&J as well as AstraZeneca vaccine is these clots that develop in the large vessels. The frequency of that is in a region of about 1 in 250,000 or maybe 1 in 100,000 to 250,000. The frequency of developing that same sort of complication, if someone develops COVID-19, is about 10 times higher. Okay, your frequency of developing these complications are much, much greater when you have COVID-19. In South Africa, the chances of being struck by lightning, or in Johannesburg, the chances of being struck by lightning is in a region of about 1 in 250,000, which is around about the same frequency of developing those sort of clotting events. So when you think of risk, you need to think of it in terms of risk benefit, and you need to also consider risk in relation to other things which you deal with on a day-to-day basis. The chances of developing this thrombosis, like I said, in Johannesburg, you're equally likely to be struck by lightning. Okay, so this speaks to another question about the mu variant, and it asks us, with all the variants that keep emerging, does it mean that we will need to get vaccinated twice every year? The short answer is that it depends what your goal of vaccination is. Like I mentioned earlier, these sort of mutations that are taking place are affecting the ability of the vaccine variably to protect against infection and mild disease, but much less so when it comes to how well the vaccines protect against severe disease and death. And these mutations that are happening are going to happen irrespective of whether we're vaccinating or not. The chances of these mutations occurring when fewer people are vaccinated is much greater, simply because there's more virus circulating, more transmission taking place, and a greater likelihood of these mutations taking place. So at the end of the day, the mu variant probably is not as resistant as the beta variant that circulated in South Africa in November of last year. The beta variant for some vaccines, as an example, the AstraZeneca vaccine, the antibody that was induced by that vaccine had very little activity against the beta variant. But the AstraZeneca vaccine now has reasonably good activity against the Delta variant. So these variants are going to come and go, and we need to stop confusing ourselves. We need to stop hyping the sort of mention of these variants, which unfortunately is something which creates more confusion than assists the public in understanding the risk that is posed by these variants. So yes, we will continue seeing variants beyond mu. By the end of this year, I suspect we'll be at the end of the Greek alphabet as well. And then we'll need to start off with another naming system. But that is nothing to be afraid of, provided that the vaccines still do what they're mainly designed to do, and that is to protect against severe disease and death. So how frequently will you need to be re-immunized? It depends on what the goal of vaccination is. If the goal of vaccination is to protect against severe disease and death, the modeling currently indicates that individuals at high risk of ending up in hospital and dying, they might need to be vaccinated every 2 to 3 years. Obviously, the virus hasn't been, or the vaccines haven't been around with us for that long, so that time period might actually change over time. But right now, I think a reasonable estimate is re-immunization every 2 to 3 years, and particularly for people that are at high risk of developing severe COVID and dying of COVID. Another important thing which speaks to the next question on the Q&A, the vaccines do differ, and we shouldn't fool ourselves. Just like not everything is equal in life, all of the vaccines are not equal in terms of how well they perform. So what we understand from the vaccine trials that have been conducted is that there is variability, anything ranging from 60% to 95% protection against infection or mild COVID due to the original virus. The vaccines that seem to induce the highest antibody response are the vaccines that have the highest efficacy or works most well in protecting against infection and mild COVID. 2 doses of the Pfizer vaccine, as an example, will reduce your risk of infection and mild COVID by up to about 95% for the alpha variant or the ancestry virus, and probably in the region of about 50 to 60% when it comes to the Delta variant. Other vaccines that induce a more modest immune response, and unfortunately that includes the J&J vaccine, protection against infection and mild COVID will be less, but protection against severe disease and death is still extremely high, even for a J&J vaccine. As you know, recently in the Sinovac trial in South Africa, and this was probably because of cases due to the Delta variant, the Sinovac trial in healthcare workers showed 97% protection against death and around about 75% protection against COVID hospitalization. So vaccines do differ. That has got implications in terms of how well to protect in protecting against infection and mild COVID. But it's got less of an issue and less of relevance when it comes to how well it will work in protecting against severe disease and death. Okay, so we've discussed a booster dose. Mande, is there anything else you wanting to say about booster doses?
I think that that's been actively studied at the moment, and there's nothing more we can state right now other than what you've said. Thank you.
Okay, next question, a really important question. What will Wits policy be on staff and students vaccination? Given everything that we have learned so far, it seems unreasonable to expect staff and students to return to campus with so many choosing not to be vaccinated. It puts us at unnecessary risk in the workspace. So the important thing there is that, yes, we need to get students and staff vaccinated. And those students and staff that choose not to be vaccinated, we need to put into place adequate measures that ensure that the chances of them infecting others on campus is minimized. And that would include possibly needing to go through a manual screen each day when they come to campus, not just basically trying to cheat the logbox system, but rather doing a manual screen, in addition to which there might well be a requirement for people to actually test themselves each week and prove that they're actually negative to ensure that they don't pose any more of a risk to other staff and students on campus that have done the responsible thing and have got vaccinated. So these are issues that are being deliberated at the highest level in the university, and hopefully over the course of the next week or two, the university will come out with a position when it comes to COVID-19 vaccination and individuals that choose not to be vaccinated. So I don't think that we should all be punishing ourselves collectively because of people that choose not to be vaccinated. Rather, the burden of choosing not to be vaccinated, that burden needs to be placed on the shoulders of those individuals that choose not to be vaccinated, be it student or staff. Okay, I would like to find out about how safe it is to vaccinate if you have blood clots. Like I said, some vaccines do have side effects of blood clots more than other vaccines. The non-replicating vector-based vaccines, which is the AstraZeneca and J&J vaccine as an example, you're more likely to develop blood clots with those vaccines. But again, important to emphasize the frequency of that is in the region of 1 in 250,000 or at best 1 in 100,000. And it's more likely to occur in women under the age of 50, 45. If you are in that category and if you are truly concerned, then perhaps choose the Pfizer vaccine, 2 doses of the Pfizer vaccine. The messenger RNA vaccines, which the Pfizer vaccine has not been associated with as high a rate of blood clots compared to the J&J and AstraZeneca vaccine, which itself, like I said, is a very low rate to start off with. Okay, which of the 2 vaccines, Pfizer and J&J, are more safe? Both of them are safe. The chances of developing side effects from both of them is extremely rare. The Pfizer vaccine, as an example, causes another condition, which is mild inflammation of the heart muscle, known as myocarditis. That is more likely to happen in males, especially males under the age of 35, as an example. But again, that would be a self-limiting side effect of the vaccine. The majority of individuals that develop that probably won't even know they developed it unless you go and get examined for fast heart rate or palpitations. You can feel your heart beating. But generally self-limiting. So all vaccines, unfortunately, do have some side effects. But again, the frequency of the side effects is what you should also consider when making a choice as to whether you should, which vaccine you're wanting to use, and certainly not making a choice as to whether you should be vaccinated or not. Because again, to emphasize, the chances of a life-threatening side effect from vaccines, a life-threatening side effect now, like I said, 1 in 250,000 people might actually develop this clot. The chances of dying of that is about 25%. So your chances of dying of that type of a clotting side effect is 1 in a million. The chances of dying of COVID-19 vaccination having a fatal side effect is in the region of about 2 to 4 in a million. The number of people that have died of COVID-19 in South Africa up to now is 4,000 per million. So 1,000 times more likely to die of COVID-19 than to die of a side effect of COVID-19 vaccines. And that is the context that we need to sort of keep at the back of our minds. Okay. Next question comes about, is there anything that you can take to enhance protection against COVID-19 if they have a possible reaction to the first dose of the Pfizer vaccine? So there isn't anything, if you've had a reaction to the first dose, and it depends what type of a reaction. Everyone that gets vaccinated, not everyone, 40 to 50% of people that get vaccinated will have some side effect, like bruising, injection at a pain of pain at the site of injection, or a mild fever, or headache, or even a stuffy nose. But that is usually a self-limiting side effect. It lasts maybe 24 to 48 hours and then resolves on its own. Those sort of side effects are not what should concern you about getting another dose of vaccine. Unfortunately, with a Pfizer vaccine, the frequency of those side effects are usually more common after the second dose than after the first dose. What you need to do is just treat it symptomatically. If you've got a fever, if you've got a headache, take Panado as an example. And sometimes what people also suggest is take Panado before you actually get your vaccine. That was done for the AstraZeneca vaccine. It didn't affect the immune response to the vaccine. So if you have had a side effect the first time around, it might be a reasonable thing to take 2 Panados before you get your next dose of vaccine, and probably repeat the Panados every 12 hours for the next day or two. But again, it's not going to guarantee that you don't have any sort of local self-limiting side effects or develop a mild fever. That's not what you should be worried about. If you have had a severe allergic reaction to the vaccine, then the next dose, you can still get a Pfizer vaccine, but it needs to be, as I mentioned, done under very secure conditions. You need to be in a facility where they got adequate equipment to ensure that if you have an anaphylactic reaction, that they're able to provide you the necessary medication to avoid serious harm. As a messenger RNA technology used in a Pfizer vaccine proved to be any more or less effective than the adenovirus technology that is used in a J&J vaccine, or the inactivated vaccines that are used by Sinovac. Right now, the Pfizer vaccine, when it comes to protecting against severe disease and death, like I emphasized earlier, all of these vaccines have high levels of protection. When it comes to protecting against infection and mild COVID-19, the Pfizer vaccine, 2 doses of the Pfizer vaccine, the Novavax vaccine, which is not available in South Africa, vaccines that induce a much higher antibody response do have a higher level of protection in protecting against infection and mild COVID-19. Does the J&J vaccine have more side effects in people under the age of 50? I think that speaks to the issue of the blood clots, which seems to happen more in people under the age of 50, especially females. But again, the frequency of that is extremely uncommon. Which of the vaccines are most efficacious against new and emerging variants, such as the Delta variant? I've sort of answered that. Again, all of these vaccines protect extremely well, irrespective of the variant, when it comes to severe disease and death. Perhaps less so when it comes to, more modestly so, when it comes in protecting against infection and mild COVID. Okay, there's a question here. There are reports in the US, Europe, that people that have been infected with COVID and then get vaccinated, they have a much better immune response. And that is true. And that, in fact, is also true for South Africa. In our vaccine trials, both the AstraZeneca vaccine and the Novavax vaccine, which I evaluated with others in South Africa, we also showed that individuals that had previous COVID or were previously infected with the virus, after a single dose of the vaccine, their immune response was better than after 2 doses of the vaccine in people that weren't previously infected with the virus. And in fact, there was very little benefit for a second dose of vaccine in people that were previously infected with COVID-19. The problem is that we don't know, unless for the 3 million people that were documented to have COVID-19, in addition to the 3 million, there's probably another 27 to 30 million people in South Africa that have been infected with the virus without actually knowing it. Because the large majority of people that were infected with the virus were either asymptomatic or they didn't actually even bother going for testing because they had a mild infection. Those individuals do have immunity against protection, but we can't second guess who those individuals are. Or whether you're part of the 70% or part of the 30% that weren't infected, no one knows unless you do an antibody test, which isn't a very efficient way to roll out vaccines because that itself comes with a price, with a cost. So we assume that everyone is unvaccinated, but in the context of South Africa, after you've received your first dose of vaccine, because of the large majority of people having been infected with the virus knowingly or unknowingly, you will already start deriving benefits probably 1-2 weeks after that first dose, rather than needing to wait after 2 weeks after the second dose. Can we expect new and better versions of COVID-19 vaccines? Absolutely. Scientists are working on that. And hopefully in 2-3 years from now, we might have a vaccine against coronaviruses that don't only protect against SARS-CoV-2, but it protects also against other coronaviruses. But obviously waiting for a 2 to 3 year period comes at a cost. It comes at a cost of loss of life. So we can't wait for that ideal vaccine to act. We need to act now to be able to impact immediately on what is happening in South Africa and globally. Can the Pfizer vaccine be mixed with other vaccines to provide greater protection against existing and new variants? The answer is we don't know. What we do know is when you combine the AstraZeneca vaccine with the Pfizer vaccine in that order, you get a better immune response in 2 doses of the AstraZeneca vaccine or 2 doses of the Pfizer vaccine. Those studies have not yet been done for the J&J vaccine and the Pfizer vaccine. But the AstraZeneca and the J&J vaccine are very similar in a construct as well as the immune responses that they induce. Hopefully in a few weeks, we will have an answer as to whether you can mix J&J with Pfizer. But on first principles, there's very little reason why you shouldn't be able to mix J&J with Pfizer and get a similar sort of response compared with AstraZeneca and Pfizer. So hopefully we'll have an answer soon on that particular question. Okay, my brother-in-law has taken his first Pfizer vaccine and the work is now arranged for J&J. Can vaccines be mixed? Like I said, vaccines possibly can be mixed, at least the AstraZeneca and the Pfizer vaccine up to now. Pfizer followed by J&J is probably not what you're wanting to do. You're probably wanting to use J&J before Pfizer. So if they've previously used Pfizer, I would suggest that they actually follow it up with a second dose of Pfizer rather than having the second dose as the J&J vaccine. How effective has the virus been in preventing severe illness and death in people above the age of 65? Extremely effective. So one of the problems that we face is that you see in social media that 65% of people that are being hospitalized in Israel or in the United Kingdom have been vaccinated. That is very true. When 100% of the population are vaccinated, 100% of people that are hospitalized with COVID-19 will have been vaccinated. That 100% doesn't mean much when it's 10 people that are being hospitalized, as opposed to when it's 100,000 people that are being hospitalized in an unvaccinated population. So when we look at data, we need to look at it more than at a superficial level. And it can be very misleading when you start reporting on 65% of people that are hospitalized have been vaccinated without actually looking at the rate per capita. So that 65% of people that are being hospitalized, that have been vaccinated, per capita of people that have been vaccinated that are hospitalized, that might be in the region of 10 per 100,000. As opposed to 1,000 per 100,000 in an unvaccinated group. So what we see with vaccines in Israel itself, where all of these discussions have arisen, is that when it comes to protecting against severe disease and death, the effectiveness of the vaccine ranges between 80% in people above the age of 70 to up to 100% in people under the age of 35 as an example. So 80 to 100%. For people with underlying immunosuppressive conditions, probably you're looking at 80% protection rather than 100% protection. So yes, you do get breakthrough infections, but important, you need to be cautious how you absorb the type of information that goes out in the media, which unfortunately the media sometimes report at the superficial level rather than actually getting to the more nitty-gritty, the more granular interpretation of the data. Okay, does South Africa have enough Pfizer vaccine for everyone? Short answer is that South Africa right now has got more vaccine in its depot than it's getting into the arms of people. So the one good thing that's happened in South Africa over the past few weeks is that we now got security of supply of vaccine. And the challenge is not vaccine security or supply. The challenge is getting people forward, dispelling the myths around COVID-19 vaccine, getting people to understand the only way to get back to a relatively normal lifestyle is to get vaccinated as soon as possible. Is there any problem with delaying your second dose of Pfizer vaccine? Absolutely not. You're wanting to get vaccinated as quickly as possible, but you're probably even better off if you delay vaccine to 6 to 8 weeks after the first dose. Your immune response is actually better with the AstraZeneca vaccine as well as the Pfizer vaccine when administered about 8 weeks after the first dose, compared with after the 4 weeks after the first dose. And like I mentioned earlier, in a South African context, 70% of people have already got equivalent of a first dose by virtue of having been exposed to the virus. And that one dose that you're going to get is going to take your antibody responses to where you want it to be. And then that additional dose is really going to top you up even further. And the longer you delay that additional dose in that instance, probably the better from an immune perspective. I vaccinated in March. Will the time come when I have to vaccine again? So I can only assume that you are one of the healthcare workers. And I think this is a discussion that's taking place in the healthcare fraternity at the moment. And healthcare workers, as an example, are a group of individuals that we're wanting to optimize protection, even against infection and mild COVID. And the reason for that is not just because of the individual benefit, but because of them needing to look after patients who might be vaccinated, but might not derive adequate protection from vaccination because of an underlying medical condition. Healthcare workers, unfortunately, are an important source of transmission of the virus in hospital settings. So we need to do as much as possible to ensure that we get as high levels of protection as possible in healthcare workers, not only in protecting against severe disease, but also in terms of how well we're able to protect them in being infected and being protected against mild COVID, which prevents or reduces the chances of them transmitting the virus. If I'm asthmatic and battling with my chest, when is the best time to get vaccine? As quickly as possible. You should not need to wait to clear up for the asthma to clear up, because what you sort of predisposing yourself to by delaying vaccination is that if you get infected with the virus, you're going to end up in hospital, especially if you've got severe underlying asthma. So if you don't have a fever, if you've got a chronic cough, that doesn't mean you shouldn't be vaccinated. You need to get vaccinated as soon as possible. And the person that's looking after you will basically determine whether there is a reason to delay vaccination, perhaps for a week or so. Okay, a recommendation for women that are pregnant. The recommendation for women that are pregnant, the Department of Health indicates that women can be vaccinated at any time. The WHO and my feeling is that women should be vaccinated from the second trimester of pregnancy onwards, not during the first trimester. So I would delay vaccine at least until 14 weeks of gestational age before coming forward for vaccine. Is there any evidence that shows that vaccines can be harmful to the fetus? The answer is no, but there is evidence which shows that COVID-19 during pregnancy results in women being about 30 to 40% more likely to have a preterm labor. So COVID-19 during pregnancy actually results in premature labor, and women that are pregnant, when they develop COVID-19, they're more likely to end up in hospital, more likely to end up in ICU. If you're pregnant, I strongly recommend that you receive, that you get vaccinated from the second trimester onwards. Okay, so why should we get as many people as possible vaccinated, seeing that vaccines don't prevent transmission? It's not that vaccines don't prevent transmission. Vaccines do prevent transmission, not 90% of transmission, but 50% of transmission. And like I said at an earlier stage, when that 50% is compounded across a community, that 50% adds up in a much greater number than just 50%. So I gave you an example with the experience of vaccinating children, where the vaccine only prevented 50% chance of the child becoming colonized with those bacteria, but that translated into massive reductions of death from pneumococcal disease in adults that were not vaccinated, because the children were now 50% less likely to transmit the pneumococcus to adults. So it's a misnomer that vaccines don't protect against infection. They do, but they protect less well against infection. But at the same time, even a 50% reduction in terms of risk of being a transmitter materializes in huge number of additional infections being avoided. Okay, we discussed a third dose for people with immune suppression. Okay, there was a CDC statement about the J&J vaccine and no data with the boost of the Pfizer vaccine. Currently, like I mentioned earlier, the data is there for the AstraZeneca vaccine, followed by the Pfizer vaccine, and hopefully the J&J and Pfizer vaccine data will be forthcoming soon. In the meantime, I think we need to then ask, well, what about the second dose of boost for the J&J vaccine, which has been shown to increase the antibody responses 9-fold, I think, 6 months after a person has been vaccinated. And I think for healthcare workers, if the Pfizer vaccine is not being offered in the immediate future, then the J&J vaccine should be offered as a boost. Okay, there's concerns about long-term side effects of the messenger RNA vaccines that might manifest in a few years. Okay, so I think the issue about side effects, what we need to understand, and this has been the legacy of vaccines, is that a majority of side effects of vaccines usually manifest within a period of 2 to 3 weeks, and usually under a week of being vaccinated, not even 2 to 3 years later. So vaccines usually manifest with side effects 2 to 3 weeks later. Very rarely, it might be 2 to 3 months later. But I haven't come across vaccines which manifest with side effects years and months later. Now, there is a sort of perception that messenger RNA vaccines are something that is completely novel. Yes, in the field of mass use of these vaccines, it is something that is novel. But the messenger RNA technology has been with us since the early 2000s, where it was being used to develop vaccines against other organisms. But those vaccines never ever materialized because the need for those vaccines wasn't as urgent as was the case for COVID-19. Are COVID-19 vaccines going to have long-term side effects? There's nothing absolute in science, but it would be extremely unusual for this sort of side effects to be manifesting years from now. The side effects that they have manifested have usually manifested within 2 to 3 weeks. Right now, probably close on to 2 billion doses of messenger RNA vaccines have been administered. 2 billion doses. And if we were getting those sort of side effects in any meaningful way, we would have been documenting it, especially since the majority of those messenger RNA vaccines have been used in high-income countries that have got extremely robust systems in place to actually identify side effects. And some of those vaccines were administered already 7-8 months ago, since November of last year. Okay, the recent third wave looks more like two distributions superimposed. Does the panel believe that diluting is sufficient explanation? Okay, I think this is going to a really epidemiological sort of field. The reason why we actually are seeing differences across the provinces when it comes to the current Delta resurgence. In Gauteng, we had a nice sort of bell-shaped curve, similar to what we experienced in the first and second wave. In other provinces, in the Free State, they sort of got a slow burn with humps coming every now and then. In KwaZulu-Natal, in the Western Cape, the reason why there was probably an initial decline is they went into level 4 restrictions before the resurgence actually peaked, unlike in Gauteng. And as they went to lower levels of restriction, irrespective of what happened in KwaZulu-Natal, they found that they got a rebound. And in some places, because of what happened, as an example, in KwaZulu-Natal, that rebound might be worse than in another province that didn't have as much civil unrest. So it's very complicated, can't be attributed to any single factor, but the civil unrest and the gatherings that took place certainly could have contributed to it. Okay, consider the start of booster jabs in the UK and US. Would the panel estimate this will happen in South Africa? Extremely unlikely in the near future. Our priority is to make sure that everyone gets at least a single dose of vaccine. And we certainly shouldn't be doing what the US and UK are doing, and that is depriving access to vaccines in less fortunate countries that simply aren't getting access to vaccines because of countries such as the US and the UK wanting to try to prevent infections when these vaccines are not going to be sustainable in protecting against having long-term protection, in getting protection against infection in a region of 90% or above. So we need to make sure that we get as many people protected against severe disease, and then we need to ensure that other people in other countries are also getting access to vaccines to at least deliver on an immediate goal, and that is to protect against severe disease and death. Considering the present vaccination rate, where do the panels think we will be in December 2021 and February 2022? That largely depends on what we do as a society, as individuals, and how we actually encourage others in our proximity to be vaccinated. If every student gets 10 other students to come to the facility that's been set up every day, we will have completed vaccination of 40,000 students by the end of this year. So it's about how we buy into this concept and stop being selfish, stop depending on others being protected for our protection, and ensure that we actually move ahead and mobilize our communities, the people that we engage with, to come forward to be vaccinated as quickly as possible. Okay, can we expect a fourth wave? We're going to get in, even if we vaccinate 40 million people by the end of tomorrow, South Africa will still experience a fourth wave and probably a fifth wave next year. That fourth wave probably will be around about November, December. But the difference is that fourth wave won't result in large number of hospitalization and death, which means there won't be any reason for government to go to higher levels of restriction. The only reason we need to go to higher levels of restriction in South Africa is not because of people getting infected to the virus, but rather because of us wanting to prevent overwhelming of our healthcare systems. And the way to do that is to make sure that people are actually vaccinated. How would boosters help if the spike protein is somewhat resistant to antibodies? Like I said, when we talk of resistance is not absolute. And it also depends on the variants. And some vaccines are able to overcome that sort of relative resistance based on the amount of antibody that's induced. The higher your antibody is, the more likely you're able to be protected against infection and mild COVID, irrespective of the variant. It depends on the amount of antibody that's actually in place based on the initial work that's been done, trying to determine what is the character of those individuals that are vaccinated, that are protected against infection, as opposed to those that have breakthrough infections. So by getting this second dose for the healthcare workers as an example, by getting that boost dose, you're taking your antibody levels up, and it might be healthcare workers as an example, are the category of individuals that might well need repeat boosters every year to ensure that they still have high levels of protection against infection and mild COVID, so that they don't become transmitters in the healthcare setting. My elderly household members do not want the vaccine. If I take the vaccine, will it indirectly protect them? Like I said, it reduces their risk of you infecting them by about 50%. But I would strongly advise that you actually speak to them, try to convince them as to why it is absolutely essential, them being elderly, for them to be vaccinated. Are the blood types separated at SNBC, Mande?
No, Prof, they're not vaccinated, they're not separated. In fact, they don't even ask whether you're vaccinated or unvaccinated at this stage. So there is a likelihood that you could get blood from a vaccinated or unvaccinated person.
Okay, someone developed polio at age 3 years and is now 67 years of age. Well, it's really lucky to have survived so long. So wishing that person good health, but you really don't want to compromise your safety any further by chancing not being vaccinated, if that was a question. How can we get the same amount of vaccine injected into us regardless of age, weight, etc.? A good question. The answer to that is that it's impossible to customize the dosage of vaccines. Logistically, it's not possible. So when we do the studies, what we do is that we include people of different sort of demographics, as well as different weight, different age, etc. And we see what is the sort of population response. And that guides us as to what dose of vaccine we should use. So we can't customize vaccine based on a specific age, and we assume that adults, most of them would be above 45 kgs of weight. So in children, as an example, we are looking at lower doses of vaccine because they are smaller. So you might well require lower doses of vaccine. But for adults, we usually generally, for all vaccines, it's basically across the bin. We don't customize the dosage. Okay. Scott and Mande, what was the delays setting up a site at Wits?
Thank you, Prof. Yes, so the Wits vaccine site has opened up now. Prior to this, as we were using the close sites, which is at Charlotte Maxeke Academic Hospital, also site at Hillbrow, also site at Yeoville. And then there was a time where we were busing our staff and students who are over 35 to the Gallagher vaccination site. And of course, we were busing students to the Liberty site, which is right here in Brom. So for a long time, we've had sites relatively close to campus. And now we're moving into the phase where we want to bring the vaccines to the people. So with that initiative, we've now set up the vaccination site here, and we're bringing the vaccine on campus so that many of our students and staff now that are now 18 and over can get vaccinated. So that's another reason for our vaccination site now, of course, is much of our population is now 18 and over, and we can then help facilitate the vaccine right here in campus.
Okay, so I guess the next question has to be from student. How does vaccine affect your sexual health? Be rest assured it doesn't decrease your libido. And in fact, there's no reason to believe that vaccines are going to cause infertility either. So nothing to worry there. I had COVID and recovered. therefore I have natural immunity. Is the evidence that vaccine-induced immunity is better than natural immunity? A really good question. And the short answer is we don't know. And in fact, if you had a past infection, like I said, that actually is a good, probably provides you good protection against severe disease and death. Probably as good as 2 doses of a vaccine in individuals that weren't previously infected. But you don't want to take a chance of getting natural infection for immunity, because for the 240,000 people that have died, they obviously don't have the choice as to what they would do next. So you don't want to form part of that statistic, and they didn't have a choice for the best part. So if you've had previous infection, you've recovered from COVID-19, that's good to hear. My suggestion is to get at least a single dose of either the Pfizer or the J&J vaccine, and that will sort of boost your immune response and provide you probably more protection. But at the same time, I think your chances of ending up in hospital if you've recovered from COVID-19 is probably very low. I had very bad COVID, taken more than 2 months to recover. Someone has taken that question off. If you've had COVID-19, you probably should wait at least about 2 months before being vaccinated. The reason for that is that COVID-19 can actually affect your immune system. And you wanting your body to be, like I said, you also do already have some level of protection from having had COVID. So it's not to say that you're susceptible to developing COVID in the immediate future, having recovered from it. And to get your better immune response, you possibly want to wait at least about 2 months. In fact, there's a study which shows that people that waited 3 months have a better immune response after recovered from COVID than people received the vaccine 1 month after having recovered. What is the best time gap between 2 shots of vaccine? 8 weeks. How safe is 1 dose of Pfizer vaccine? 1 dose of the safety of the vaccine, 1 dose is safe, 2 doses is also safe. And if you're using the Pfizer vaccine, you're wanting to optimize your protection and get 2 doses, because we don't know whether you've been infected previously or not. What are the next timelines for South Africa's programs in planning for booster doses for clinically vulnerable? Unfortunately, the Department of Health would need to pronounce on that. Like I mentioned, there's a good case to be made for people with cancer, with renal failure, and other underlying medical conditions to be boosted sooner than later, probably before the next resurgence occurs, which is anticipated in November, December. My 87-year-old grandmother and my father's 67-year-old best friend both passed away from COVID-19. My condolences to have heard that, despite having the first Pfizer jab of vaccine. So I think this is a problem. And there's 2 issues at play. When you are vaccinating at a peak of a resurgence, unfortunately, our experience when we did our clinical trials is that up to about 15% of people that were being vaccinated at a peak of the resurgence are actually infected with the virus when they're coming forward to be vaccinated without knowing it, because the virus is just so wide, ubiquitous. And some people, unfortunately, have died a few days or developed COVID-19 a week after being vaccinated or a few days after being vaccinated. It's not the vaccine that's causing COVID-19. The vaccine doesn't have the ability to cause COVID-19. It's just a temporal association of some people having been unfortunate to have been infected with the virus, and that when you get vaccinated, the vaccine doesn't actually prevent the clinical cause of that infection from progressing. Vaccines take time to work, up to about 2 weeks, and sometimes up to about 4 weeks. So unfortunately, there's sort of instances where people have died between the first and the second dose, especially in that particular age group. It's really, really unfortunate. After a single dose of the vaccine, we probably expect about 60 to 70% protection against severe disease and death. After 2 doses of the Pfizer vaccine, that goes up. But for someone that's 87 years old, even after 2 doses of the vaccine, that protection is only going to be in the region of 80%. So vaccines don't guarantee that you won't end up in hospital and die, but it will significantly reduce the risk of ending up in hospital and die. So that's the reason why a single dose of vaccine, and even a single dose of the J&J vaccine, you require at least 21 days. And even then, protection against severe disease, hospitalization would be in the region of 75%. Answer that one. There are theories that the true side effects of the messenger RNA vaccines will only manifest in years to come. My understanding is that once it leaves the body, it's gone. The RNA itself, so just for people that aren't clear about RNA, these are not living organisms. And when it's administered, it actually doesn't integrate into the DNA. In fact, all that happens is that it uses the host cell machinery to produce an antibody, and it actually degrades almost immediately. The RNA doesn't last in your body. It degrades as soon as that message is read by the ribosomes. Using the cell machinery, produces the spike proteins, which is then sort of presented to the immune system to respond to. So RNA does not integrate into the host DNA. And it can't cause any sort of long-term side effects because, like you mentioned, it degrades very soon after a person has been vaccinated. So again, over 2 billion doses of RNA vaccines have been used, and we haven't seen any sort of mutants starting to evolve. That is, mutants in terms of people growing horns or anything else. If I tested positive for COVID-19 and lost the smell and taste, how long does it take to recover? It can take up to about 3 to 4 months. Usually the recovery is about 3 to 4 weeks later, but sometimes those sort of symptoms can take even 3 to 4 months to recover. Should worried individuals be screened for predisposition to clot formation? So the answer is no. And I think it's just not pragmatic for people to come forward to screening. I think the type of precautions you're wanting to take is that if you do have a predisposition to clotting events, perhaps then consider using the Pfizer vaccine rather than the non-replicating vector-based vaccines. And again, if you're a woman under the age of 50, then perhaps try to use the Pfizer vaccine. But like, again, it's important to emphasize that the J&J vaccine is better than no vaccine, because the risk of those clotting events is extremely uncommon. Again, to emphasize, in the region of probably 1 in 250,000. Is there a new J&J vaccine? There are new vaccines that are being developed for all of the COVID-19 vaccines, the AstraZeneca, J&J probably, the messenger RNA vaccines. But what we've experienced since January is that the frequency of these mutations is such that it's unlikely that we can continue topping up people with new vaccines against a new variant. And importantly, we need to become comfortable with the virus, learn to live with it, ensure that we get people protected against severe disease and death, and get on with our lives. Okay, this is someone that makes it clear they're not an anti-vaxxer. I would like to know, is there research into causes of death post-taking a vaccine? Is there research body investigating causes of death rather than merely ruling out COVID-19 vaccine? To place in context and from personal experience, I was not asked if my late parent had been vaccinated in the first place. It seems like they only monitor the effects of the vaccines for 15 minutes. Okay, so I think the important thing here is that South Africa doesn't have a very robust, what we call an adverse events reporting system. High-income countries have got that. And that is where we get this sort of signals on myocarditis, thrombosis, etc. From high-income countries that have got very robust systems in place, surveillance systems in place to monitor for serious side effects. In South Africa, we're actually setting this up right now at Chris Hani Baragwanath's hospital, at Charlotte McQuarrie, at Helen Joseph Hospital, where we're setting up an active surveillance to actually determine the frequency of these severe side effects. So all that we can do currently is when, as an example, when SAPRA reviewed the 28 cases that were suggested to be due to COVID-19 vaccine, they can do a review of the medical records and make an informed decision or conclusion as to whether the vaccine could have played a role. And again, there has to be firstly a temporal association between when a person is vaccinated and when they develop the side effects, and then you're needing to exclude other possible reasons why a person might have died. So we need to do more of this in South Africa, and we're setting up the systems. But in the meantime, we need to rely on what would be a highly reliable information from high-income countries which have had these systems in place, not just for COVID-19, but to monitor for side effects for more than 25 other vaccines that are actually used in the population. If a student or staff can demonstrate that they've had Delta COVID, will that be good as being vaccinated? Short answer is that it will be as good as being vaccinated, but again, we can't guarantee, unless people are actually able to provide documentation that they've been infected, then they would need to be vaccinated. But if you've developed COVID and you don't want to be vaccinated, then somewhat uncertain about your experience, because anyone that developed COVID, I would suspect they would want to be vaccinated, having gone through what most people go through when they have symptomatic COVID. Okay, vaccine for the effects on fertility. Like I mentioned, no reason to believe that vaccines impact on fertility, either from a male perspective or female perspective. And again, there have been studies done in animal models, which basically looks at fertility issues in animal models before these vaccines are actually allowed to be introduced in humans. And in those animal models, there's no indication, no reason to suspect that vaccines would affect fertility. Okay, healthcare workers were vaccinated predominantly with J&J. Currently, there isn't any literature on a second dose of vaccine. Okay, so I think I've answered that question already previously, so I'm not going to repeat that. Would we please have access to the recording of this informative session? I'm glad you found it informative. Yes, the recording will be made available and posted on the Wits website. Are there any timescales for offering vaccination to 12 to 17-year-olds? Short answer is that we're needing to get at least about 80 to 90% of our adult population vaccinated before we start considering going down to a younger age group. In addition to which, I would go beyond that. I would say we need to make sure that other countries have equitable access to vaccines before we start to think of vaccinating younger age groups. Yes, they do get infected with the virus, but the chances of them ending up in hospital is really low. The main reason you're vaccinating children in a 12 to 17-year age group is to actually reduce the chances of them transmitting the virus. But that can't come at the cost of us compromising on access to vaccines in other countries that don't have access to vaccines because they're unable to actually gain access. So we need to make sure there's equity of supply of vaccines to other African countries, particularly before we start vaccinating children. There is a benefit from a public health perspective to be vaccinated, but not at much less so at an individual level. Which vaccine is preferred for pregnant women? Both the J&J as well as the AstraZeneca vaccines are recommended by the WHO for pregnant women. The body of evidence is much greater for the Pfizer vaccine in terms of its use in pregnant women, just because of how widespread its use has been. Is South Africa manufacturing J&J? South Africa, they're not manufacturing J&J from the raw material right to the fill and finish. They're doing what is known as fill and finish, which is sort of the end stage part of manufacture, where they get the active biological ingredient from J&J that is imported into the country, and then they do the filling of the vials, the finishing, and then the sort of deployment. And that is unlikely to change anytime soon. Is there any concern around antibody-dependent enhancement as a result of the messenger RNA vaccines? That has always been a theoretical concern because of past experience with the MERS virus. But our short answer is that if that was a concern, the sort of chances of that happening is minuscule compared to the number of severe cases and death that are being prevented from COVID-19. So maybe at an individual level, if there's some sort of bias in terms of the immune response, which might occur at an individual level, but not much less at a community level, there is that theoretical concern. But for all intents and purposes, chances are we wouldn't actually be able to unmask it unless you're doing post-mortems in individuals that were vaccinated and died of COVID-19. What is the best vaccine to get for the elderly to protect them as quickly as possible? Would J&J be more effective? Like I said, get the first vaccine you can get hold of into your arm if you're in the elderly group, and then try to top up with the Pfizer vaccine if you got J&J to start off with. I would suggest, yeah. So for the elderly, again, I've got my biases. My biases would point towards them being vaccinated with 2 doses of the Pfizer vaccine, unless the J&J vaccine is going to be followed by a single dose of the Pfizer vaccine, because the J&J vaccine against hospitalization showed 75% protection, whereas the Pfizer vaccine against hospitalization has got protection of after 2 doses has got protection of 90%. When will children under the age of 17 be vaccinated? I think we've addressed that. If advised by the GP and physician not to get a second Pfizer vaccine after an allergic reaction to the first, what can be taken for additional protection? Like I said, I wouldn't say you shouldn't get a second vaccine, but you should get a second vaccine in a setting and at the superficial blood clot, I'm not too sure what that means, because these vaccines don't really give you superficial blood clots. It's more about blood clots in the large vessels. But if you've had a reaction to the first dose of the Pfizer vaccine, then when you get a second dose, just make sure that you're getting it in a very controlled environment where they got adequate equipment to deal with the allergic reaction should a need arise. Okay, I think the best way to, I think we've established the best way to avoid infection, whether vaccinated or not, is social distancing and avoiding physical interaction. So the short answer to that is that is perhaps the best way, but it's simply not the most sustainable manner in which we can continue with our lives. Expecting people to continue wearing face masks and engage in physical distancing for the rest of our lifetimes, which is largely the duration of time for which this virus is going to continue circulating, I think is not being realistic. So yes, it has worked at a point in time, and it was most needed when we didn't have the tools to protect people against severe disease and death. But now that we've got the tools to protect people against severe disease and death, we need to make sure that we can actually ensure that we maximize that with a sustainable intervention. And the most sustainable intervention is vaccination. And that goes, the same thing applies for the people that you're taking care of. They need to be vaccinated. And if you're vaccinated, your chances of transmitting to them is reduced by 50%. And if they vaccinated, their chances at worst of being protected against severe disease is 80%. So the net compounded effect of that essentially is their chances of ending up in hospital with COVID-19 is probably not any different compared to the chances of ending up in hospital because of seasonal influenza. So I think we need to be pragmatic about what we're trying to achieve. There's no foolproof way of protecting people against seasonal influenza, and similarly so not against COVID-19, both at an individual level as well as when it comes to us transmitting the virus to other contexts, be it in the household or on campus. How long after infection can you get the virus? Well, you can get a virus immediately after infection. So can you get reinfected with the virus after getting COVID? And the answer is yes. And it depends on which variant. And with some variants, you can get infected much sooner than with other variants. But the concern is no longer about being infected. Once upon a time, when some people believed that you could actually get rid of this virus, and that was probably about 1 year ago, then the whole issue of reinfections was topical. Now the issue of reinfections is somewhat of a moot point, because with the virus continue mutating, people are getting reinfected, but importantly, those that were previously infected, when they get reinfected, they don't end up in hospital and dying of COVID-19. Will children between the age of 3 to 18 ever need to be vaccinated? I think I've sort of answered that. At an individual level, there's much less reason to be vaccinated. But from a public health perspective, if we're trying to lower the rates of transmission of the virus, then children should be vaccinated. If you had pneumonia a few years ago and have been fully vaccinated now, will you be more protected from developing COVID pneumonia if you get COVID-19? Absolutely. You're much more protected if you've been fully vaccinated. I had blood clots last year, and I'm also anemic. Is it safe to be vaccinated? Yes, it's safe to be vaccinated. I would suggest you try the Pfizer vaccine. If I donate blood to someone after I've been vaccinated, will they get antibodies? Yes, they will get antibodies, but the amount of antibodies they get will depend on when you've been vaccinated and how long after that you actually donate the blood. Or will the blood confer to them some level of protection against COVID-19? Probably not, because the blood is sort of segmented into its different components, and that part of the blood which is sort of rich in antibodies is not what is usually given when someone actually receives the blood transfusion. But there might be some residual antibody in that blood. My mother is 70 years old and she has thrombocytosis. The blood thickens. Which vaccine will be ideal? I would suggest the Pfizer vaccine. If one is already vaccinated 3 months ago, can they randomly decide to vaccinate again, given the liberty of vaccination sites now, or would they need to form some consultation? If you've received the Pfizer vaccine previously, then you can just come in and get your second dose of the Pfizer vaccine. If you received the J&J vaccine, unfortunately, government policy on that needs to be adapted before those individuals will be allowed a second dose of the vaccine. Mande, is there anything else you wanting to say there? Or Scott?
No, I think that's all your answers. Prof, you've been so amazing. Even I've learned today. Thank you so much. It's been a really, really good webinar. Thank you.
And thank you so much, Prof. If I don't mind, we're just going to be closing our site now. So there's some background noise, and I think Mande and I will probably be excusing ourselves. So that's fine. And just to remind everyone that the site is open now for the next 3 weeks. And as we've heard from Prof, the numbers speak for themselves. And I think the facts of the proven safety of the vaccine and the effectiveness of it. So we really encourage students, staff, and your families to come down to the site. We're open 8 to 4. You can pre-book on our website, but it's also fine just to walk in. We'll accept you as a walk-in. And our philosophy is we're not turning anyone away. We'll help you to get vaccinated. Thank you so much, Prof. I'm going to just have to step away now.
Okay, thanks, Scott Mande. Okay, so I'm going to just rush to the remaining 12 questions, and we're going to call this webinar to an end. After the J&J vaccine, how long does it take to start working? You probably get good levels of protection 21 days after the J&J vaccine, but you get some levels of protection even after 14 days. But the protection is mostly against moderate to severe disease, less so against mild infection. I received a Sinopharm vaccine. Some countries might not actually recognize it. Is it okay to get a Pfizer or the J&J vaccine? Short answer is yes, it is fine to get the Pfizer or the J&J vaccine. I keep hearing that it's better to get a second dose of the Pfizer vaccine after 8 weeks, but why does a vaccine card show that you must get it 42 days later? Like I mentioned earlier, the longer the interval between the doses of vaccine, the better. Government should probably change it, and I would recommend 8 to 12 weeks after the first dose. Is South Africa going to get the Novavax vaccine? Unfortunately, government hasn't decided whether it wants to use a Novavax vaccine, so the company is not planning on registering until government decides otherwise. In addition to which, there are some manufacturing issues when it comes to the Novavax vaccine, so it's unlikely that a Novavax vaccine would become available in South Africa, at least until the first quarter of next year. If a person had COVID 1 year ago, but is still experiencing the symptoms such as shortness of breath, does the person need to take the vaccine presently? So unfortunately, this is an instance of what we call as long COVID, and it's not something that is uncommon. The person should probably still get the vaccine, even with those symptoms ongoing, because it will top you up and hopefully protect you from the slim likelihood of developing severe COVID again. So I would suggest people that have recovered of COVID, especially if they had severe illness, still get further vaccines. Okay, we discuss the issue of children being vaccinated. Okay, I'm one of the people worried about the lack of pre-health tests to ascertain whether one won't be negatively affected by the vaccine. So there really isn't any pre-health test that you can actually do to determine the type of side effects. As an example, the thrombosis, as well as the anaphylaxis. The anaphylaxis is perhaps slightly different in that people with a history of anaphylaxis are more likely to develop the side effect. But for many of the other side effects, there's no predictor as to who it is that is going to develop those sort of side effects. We've got sort of broad ballpark figures or a broad idea that, as an example, that thrombosis is more common in women under a particular age, or the myocarditis is more common in men under a particular age. But beyond that, there isn't really anything else you can do in terms of a health test to determine whether you're going to have a negative effect of the vaccine. And again, we emphasize that these serious side effects are extremely rare. Would there ever be a requirement for family members who live with student staff members to be vaccinated, especially if they are vaccine hesitant? I think the university is within its rights to be able to have a position when it comes to vaccination of staff and members. I don't think the university ever would be in a position to be able to insist that family members of students and staff also show documentation of vaccination for them to be able to return to a relatively normal environment. So I don't think that would be within the powers of the university. A relative of mine got J&J in February and caught the virus in June. They felt lightheaded and their speech started slurring. It was similar symptoms to when they got pneumonia in 2017, but the symptoms went away quickly. Is this a sign they could have developed COVID-19 pneumonia? So unfortunately, when it comes to this entity known as long COVID, where the symptoms can persist for more than 4 weeks, and sometimes for months, and even for probably up to a year. those sort of symptoms is somewhat unique to COVID-19, and it's uncommon with seasonal influenza. And the reason for that is that COVID-19 causes disease in a very different way compared with seasonal influenza, in that it actually causes clotting in blood vessels that supply different organs. And that can end up with residual damage to those organs, which can take a long time to recover from. I keep hearing it's better to get a second dose of Pfizer vaccine. Okay, so we discussed that part. How many people get treatment for blood clots due to J&J? In a Sinovac trial, we have 500,000 people who were vaccinated. There were 2 cases of blood clots. So like I said, 1 in 250,000 people in a Sinovac trial developed the blood clots. So with that, I'm going to call this to an end. Like I said, the purpose of vaccine is not to harm anyone. Our sole goal with vaccination is to protect people against severe disease and to protect lives. And if we are wanting to really get back to a relatively normal lifestyle, and if we are wanting to get back to a normal environment at the University of the Witwatersrand and every other university, the only sustainable manner to do that is to ensure that we can get at least 90% of our staff and student population vaccinated. So again, thanks for joining us this afternoon. Hope you found it useful. Hope it answered some of your uncertainties, motivates you to get vaccinated, and look forward to you encouraging others to get vaccinated as well. Thank you, everyone.